together. So what are the unique, I think most of us are pediatric ophthalmologists, general ophthalmologists, but basically we need to also have sessions for the pediatricians, because I feel that the pediatricians are still not referring. When we go now, I know Prachi does a lot of ROP screening. I think what we have started is that along with the ROP screening, if you can also tell them that at 6 months or 1 year, if they can refer the same child to a CVI clinic or to a pediatric ophthalmologist, because you never know the delayed milestones. You think that the child is okay, but the preterm baby may also have delayed milestones, and it is picked up so late. When the pediatricians or the neurosurgeons or the neurologists tell them, ठीक है, बड़े होके ठीक हो जाएंगे. But what I've understood is that from all the rehabilitation persons, that we need to treat them, or we need to diagnose them early and start early intervention very soon. So whenever the child has a light gazing problem, that just not focusing or fixing towards light, you find that a baby who's 6 months of age and no head holding, and sometimes it is so, you find that even the pediatricians have not been able to detect, and they tell them it's okay, थोड़ा बड़े होके सब ठीक हो जाएगा. Or if you find that, see, in a torchlight, if you put the torchlight and the child is not responding at all to the light, no fixing, no following at the light. So these are the children who we need to intervene early. Like, we can't just tell them, okay, fine, be relaxed, nothing, it'll become okay by the child grows older. We need to send them to early intervention specialist. And we have an early intervention specialist here, Sachu, who will tell us the importance of treating them as early as possible. So the normal child will pick up objects, but see, this child with a CVI, he is not even responding to the light. Like, we ask him to follow the light, there is no response at all. So these are the children, sometimes they have gone, they're preterm, they have been in the NICU, they have gone through a lot of procedures, and then they come and then the parents say not fixing towards light, and the pediatricians. So if we can, at the ROP screening level itself, all preterm babies, even if they have no ROP, if they can be told, please come to our center at 6 months to 1 year. Then one of the other unique features are that they have field defects. Of course, the field test can be done with the help of a small toy. You don't need big instruments. This is a whiteboard which we have created, and then just check where the child is looking at the toy. See whether most of the children, as Dr. Nipa mentioned, that they have the posterior parietal affection, they have inferior field defects, and the child wants to walk, and there your inferior field is defected. So if we can guide them, we can help them at such an early age. The other characteristics are, this is a child who I operated for pediatric cataract, and I felt everything was fine, but the child was very slow at looking at the object, difficulty in viewing in a complex environment, and after referring to a early vision intervention specialist, found that the child improved, because the child had problems. After that an MRI was done and the child had problems. He was responding to sound but not looking at any objects on their own, even though we have operated and given him good vision after the post cataract surgery. So these are small things which we need to observe, and we need to tell the parents that they need to refer to a pediatric ophthalmologist or to an early intervention center. So they have color preference with red and yellow. So suppose if they can't get appointments with the early intervention specialist early, just ask their parents to start with we can put a torch, and over that you can put a red glaze paper or a yellow glaze paper, and ask them to stimulate. Means this red light, definitely we find that you will find yourself when you examine these kids, that when you are putting the normal torchlight, the child does not respond. The moment you put a red glaze paper or a yellow glaze paper, you find them following the light. So we can use this as a tool, simple tools, till they get an appointment, that you can tell the parents, you keep asking them to look at this, put the red glaze paper and stimulate the brain. So the key to understanding is in these characteristic CVI babies, in this behavior, sorry. So the attraction to a color, basically to the red color, light gazing, and then we find that they have latency in vision. So that's what we picked up after the child was operated for cataract, not responding to pick up. Like, it's like you have a small object kept there, 3-4 objects put there, not interested in picking up that object when you know your surgery is fine and everything is fine. So you need to find that out and find out why. Okay, the latency is poor. Then visual field differences, difficulties with distance viewing or visual reflex differences. Reflex means I'm asking the child, that look at, even this is basically when you find that the child, look at a toy and you ask him to look like basically the saccades. you ask him to look at the other toy, and you find that the child takes a long time to come to look at the other toy. So your saccades are affected, and most of these children with CVI have problems with saccades. So we need to work on that, and that again the early intervention specialist works on these. So what we need to guide them with the rehabilitation persons is that, okay, this is affected, please work on this. So that's at least that much we can do, help them, like, okay, you tell them this. Then there will be lack of visual motor match. You find that the motor system may be fine, but they are not able to coordinate. So this is the CVI range now, which is used internationally. We need not know as ophthalmologists, because this is basically done by the rehabilitation experts, but at least it helps us, because parents want to know, okay, what is my range of my child, or how much is my child seeing? Are there any predictors to say that, okay, my child has improved over a period of time? So we need to know the CVI range is that there's very minimal response, visual response with your CVI range 1 or 2. Means the child which I showed earlier is at 1, 0, in fact is a CVI range 0. 1 or 2 is that at least minimal response the child has. So O is in that all the information we get by observing the child. This is what is O. And then you mentioned that and I is which is interview through regarding the child or the student. And D is when you have direct contact, when you are seeing in the OPD itself. And then you assess how much is the degree of the CVI characteristics, and once you feel it has resolved, you write resolved, like the problem has resolved. So this is done by the vision rehabilitation experts, but as ophthalmologists, as pediatric, we should just know that, okay, this is you should tell, okay, this patient has improved from CVI range 1 to 2, it has come to 3 to 4, where there are some consistent visual responses. The rehabilitation person will tell you, okay, now she fixates occasionally. First she was not even fixating at an object. Now the child fixates. There is a latency, but at least she is trying to fixate. Okay, and then maybe the light, they can be redirected. Okay, you are looking at this object. Is the child looking at the object fast, other object, or is there a latency? Is there a gaze preference? That, okay, if the child is only looking at this gaze, not looking at this gaze, so you will tell the rehabilitation person, expert, okay, we need to make the child look at this gaze also. So you work on that the right gaze of the child is comfortable. Bring the first, make the gaze better in the center, and then shift it to the left side. So all these things we need to help the rehab, because they are not able to understand what are we seeing in the child. But if you help the rehabilitation expert, they will, okay, we'll try to improve that. The left gaze is not working at all. So we will try to improve that. So if they blink in response to touch, sometimes what we find is that they're not able to see the object. Does motion help? So you make the object move. So when you have the motion, then the child then fixes and follows the target. So these are the small things which we should record and we should help. So this is stage CV range 5 and 6, where the student uses vision for functional task. Like basically, but the problem with this is, like, it takes a lot of time to reach to 5 and 6. I think it takes around 1 year, and that patience we have to keep counseling the parents, because they switch from one rehabilitation expert to another rehabilitation. Uska kuch hua hi nahi, kuch ho nahi raha, nothing is happening, what to do next? So we should say that, okay, to come to the CVI range 5 and 6, it will take time. Please go ahead with the treatment. It takes time and we need to go ahead with that. So 7 and 8 is when the child demonstrates usual curiosity, which is like a normal child, which is the child will look up to objects, will follow the objects and all that. So in this case, like in this child, how would I tell the CVI, the rehabilitation expert, is that he has a preference to colors. There is right gaze preference, and there is difficulty in viewing, distance viewing. So this child is drowsy because he's also has NEPA pointed. It's not one thing. The child is also on anti-epileptic medicines, so they're most of the time drowsy. And if there is any atypical visual behavior, like this child does not look to the left gaze at all, so these things are to be noted down. In our OPD, can we diagnose, or can we understand what difference it has, like whether the, sometimes you feel, is it an OVI or a CVI? I'm just putting this small thing because this was made by us. Glia puzzles are so expensive to buy them, so if we can make them on our own in our OPD, just to find out. So we use the carpenter and we told them to just make a wooden thing with these size of the objects, and we ask them, we just observe in the OPD whether this is possible. And so this is what they have, is that the impaired visual guidance of movement. So you ask them to put, see, he's not able to, he has vision around 636, 624, but see, he's not able to put the objects into the, and he's around 5 years of age. So this is a child you will suspect. He takes time, so he does it, but he's taking a lot of time. So, and this is a simple, we just made it in the OPD by a carpenter. I don't need some expensive. So, and this could help, and this is exactly what the psychologist and the vision rehabilitation experts use to identify the improvement. Whether how long does a child take to do this task. So that's what is, they put it as improvement. So this is the LIA puzzle, and you find that the child is not able to coordinate the size and the shape of the object. You have a LIA mailbox. This we made in the OPD also with see, if you see a normal child will tell you where exactly to put the the card through the hole. See, he's orienting the slit, the small paper, and he's turning the card in the correct position and then putting it. So this orientation of putting the card in the correct position and putting it into this card box shows that my posterior parietal lobe is intact. It's a small test, but it is so important. It tells you that I can coordinate, I can orient the slot and then put it into the either vertical or a horizontal. So this is made in the OPD. It's a small card which we have made, but it helps us. So in this child who has a CVI, see, he's not able to do it. It's a simple task, but he's not able to orient it. Like, he's not able to make it vertical, he's not able to orient it, and he's not able to put it through the slot. So this is how we can identify children with CVI, and we can tell them, okay, that's why the vision is less. So we need to work with the expert or the special educator or the neuro rehabilitation experts how to do this. So vision assessment, all of us may be having the TAC or the LIA pedals. This is something which most of us ophthalmologists have, so I'm not going to go into detail. But this is the LIA pedal which is used. We have to use the LIA pedal because most of these children have very poor vision. So even with the TAC, they're not responding even to TAC. So we have the grating on each handle, and these gratings tell us. So basically, why this is important? Maybe we need not have it in practice because it's expensive. But all parents want to know, मेरा बच्चे का vision क्या हुआ? What is happening to my child's vision? You are just examining and saying the child is following. You know, what is happening? Okay, I'm doing a therapy for 1 year. I'm doing it for 6 months. Is there an improvement? So I show them, okay, with the LIA pedal, okay, it has improved from 12,800 to 2,900, something like that. So that is how it is. It is done. So this is so you can place it vertically or horizontally. So you need these LIA pedals, and they do help us to quantify the vision in these children and help us to say, okay, this is improving or so TAC is something I think most of us have this. Refraction, a cycloplegic refraction. Of course, most of these we will not put cyclopentolate. We will do an atropine or a homatropine or a T-plane refraction, and that's what we'll be doing. It is important to check the accommodative status because most of these children have some anomalies of accommodation and they have the lag of accommodation. So we need to do the MEM, the lag of dynamic retinoscopy, the monocle estimate method, where we have to find out whether how much of lag is there in the patient. So now either if we do not want to do that, if the child is very uncooperative, you all have the trial set, see with +3 or +4 or +5 glasses, the child is seeing better for near. You don't need to put, you don't need to do if the child is very uncooperative. And if the child, you feel that the child has started focusing, the child was not focusing at all, you put a +5 or a +8. This is what Leah taught me, Dr. Leah. She said you just put a +8 and see how is the child responding. If the child laughs, very happy, you say that you give this glasses because that means there's so much of lag of accommodation that the child needs some more than plus numbers to see clearly. So this is a simple test which you can do, but otherwise you could do a lag of accommodation, the MEM, and see with the against movement how much he needs to neutralize it. They may not be very cooperative, so you can do these plus glasses. So contrast is something which we need to all know, but of course hiding Heidi again is pretty expensive. This thing is. So we could use this to see how much of contrast the child has lost. So this is the hiding Heidi. So we can say whether it is 5% loss or a 10% loss or 100% loss. Then we can tell the rehabilitation expert, okay, the child has problems in contrast. So it is important for visual communication and in orientation and mobility. So what they do is that they ask the parents to put dark lipstick, bindi, and also that the child can focus on the mother much more clearly. So these are the small things why we need to do these tests. So we need to tell them like, okay, this hiding ID is a test, but these are this is from Leah what we have bought, but we could we'll have to make our own, I think, because all these are so expensive. So we have published a paper and we found that most of our common presentation, because I was strabismologist, most of them are strabismus. I don't think it is the most common presentation is strabismus. It has to be poor eye contact, poor visual response. But for me, all were referred to me because of strabismus. So, and we found PVL, and our most common cause was hypoglycemia, the etiology. So I think that is such a that thing which we can prevent, hypoglycemia. It is just that a child has not been given even vati like the milk, such a small thing, but we could just say that okay, give them milk in the vati if the child is not breastfeeding. 1 or 2 days of no breastfeeding is enough for the child to cause an hypoglycemic attack, and that's how CVI occurs. So we have to be conscious. I think we all need to go and talk to the neonatologist and the pediatricians and the gynecologist for all this. So neuro-ophthalmic findings, we find that mostly constant exotropia. So we have gaze deviations which you saw in that patient, and optic disc, we find that mostly they are hypoplastic disc, or we have most of them are referred to the glaucoma because it is a pseudoglaucomatous disc. But it's a PVL disc basically. It's a PVL disc which has a deep cup, and so there are large cups, normal disc with large cups more than 28 weeks. So in most we call them as a PVL disc. So in these cases we need to do an MRI and rule out whether it is a CVI, not a glaucoma. So strabismus was high in our case, is high as 73%. What I would only say is that because most of us are strabismologists, I would say that we need to operate them, but be cautious because most of them we have to undercorrect them. And when undercorrecting, you need to give them prisms and glasses after the surgery. Otherwise, I have landed up, because in that time I have landed up, now my patients are following up with consecutive exos. So when they improve after 3 or 4 years, they start walking, but you need to tell them that you may need to do a repeat surgery with consecutive exos in these children later. So they have found less predictable results. So we just did a study in Shroff itself, Dr. Manaswani and me, and we found that our children with neurological impairment, our main cause was most of them had cerebral palsy with birth asphyxia and HIE, has Dr. Nipa said, and seizures also. We operated them early just to see that whether we operate them early, what is happening. So I got a large amount of consecutive exos later on, and around 8%, and we found that even though the successful outcome with Dr. Meenakshi et al. Had presented, had published, ours was also outcome was 73%, which the outcome in the control compared to the control group, we had also a good outcome, 73.8%. But what I found out that sensory does not improving. So I am really now skeptical whether we should operate them less than 2 years. Let them just if it's a very constant deviation, esotropia, and you feel that it's 50-60 prisms, if it is intermittent, small angle deviation up to 20 to 30 prisms, I think just leave them alone. Just keep patching them. Don't operate them so early, because I found that even if you operate them early, they're not getting. Why are we operating early? For the sensory issue. We found that we were still we got absence stereopsis in all the 96 eyes. So I have gone through a high risk and then operated them early, and then even after 2 or 3 years, if I had operated, I've got the same result, and at least I would have got a better measurement and not got a consecutive exo. So I think this is the learning which I have got from this paper, which we are sending it for publication. So next speaker we have, I think we'll take up the together because Reena is the next speaker, and Reena, you're ready there? Yeah, it's here only. Okay. So any questions in the audience before, by the time Reena is, all of you, how many of you have the Leah pedals, or all of you are? Yeah, most of them are doing it. It's expensive. So how many have, I didn't ask this before the survey, all of us are doing CVI practice, or? Yeah, quite a large number, so that's good. So you all also give input.
Because even in our practice, we are finding a lot of patients who are presenting with hypoglycemia. Surprisingly, the issue is not there in the United States as much. I think Dr. Linda is the one who is our mentor, and we are having CVI clinics with her every 2 weeks. We discuss patients with her. But there she says that they don't see this hypoglycemia at all, and she's very surprised as to why we have so many cases in India. So probably it was not there a few years back also. Is it something to do with the exclusive breastfeeding issue that we emphasize so much, that probably they don't measure? Even I have seen babies who are in the NICU still going for hypoglycemia, which is very surprising. They are not babies who are discharged. They are right there in the hospital, but still the sugar level comes down to 20, 30 as per their records. And
I think we should take it up. I know in the forum of pediatricians and neonatologists I presented, they are themselves surprised. So I was like, no, it's there. Hypoglycemia is there. So I said, like, you have to do, at least this is something which is preventable. Okay, HIE, we can't help it if there was a cord around the neck or something like that. But at least they are insisting, what you said is right, they're insisting on breastfeeding, and they're not, at least in Maharashtra I find still there's a bati and spoon technique. In Delhi it's not much, at least in UP I don't find that so relevant that they're going to give in the bati and the spoon. They keep enforcing on breastfeeding if there's no breast milk coming.
Yeah, even in Tamil Nadu it is like that only. It is focus on exclusive breastfeeding only.
Yeah. So I think Maharashtra is doing well in that aspect. Prachi can comment if anything you can.
Thank you.
Excellent. Ma'am, really very nice discussion. I learnt a lot from this. One thing that I would like to add is when we see children, we do feel that sometimes the children have motor delay. So when we start examining them, showing them the torchlight, we should wait for their response. There is actually a latency to their motor reaction. So children who you show, move an object, you have to wait for at least a minute for them to bring their motor system to align with where your object is, and that delay is seen. Another thing what we do also realize is sometimes their midline is not as developed, so they prefer to see with their peripheries, and that is another thing. So when it might seem like the child is looking elsewhere, but the child is actually focusing on the object. So if we do see motor responses from the head, I think one is to wait for their responses, and the second is to see what their preferred head posture is, and though they might be looking somewhere else, they're viewing eccentrically through and to the object. So
that's a good point, very nice point. I think this is also something which we should also write and work on. Yes. That's the next topic. And then if she doesn't cover, I'll answer. Okay, now we have Reena here, who will be helping us to differentiate. She'll be helping us to differentiate between OVI and